We all know that this is a forum to understand more about diabetes and its related implication on long-term aspect of morbidity and mortality as well. So when we look at any diseases which is very important in terms of morbidity and mortality, one thing we really need to understand is the primary prevention. So the primary prevention is very much been highlighted in most of the non-communicable diseases, diabetes, hypertension, obesity, myocardial infarction, etc. But when we look at diabetes related foot disease, that's a new term which has been used very frequently in all across the globe. If you look at that, primary prevention has not been considered as a major groundbreaking thing in terms of understanding and preventing. But if after an hour, we thought we highlight what is very important in understanding about the primary prevention in diabetes related foot disease. So I would like to definitely acknowledge this gentleman who I'm sure most of us you by now know, because I showed the same picture last time as well. This is Dr. Paul Brand, who is actually a pioneer in Hansen's disease. But if you look at most of the offloading as well as the pathophysiology behind diabetes, if you look at it's the Hansen's disease pathophysiology is almost similar to diabetes in terms of the deformities, but you can see in the right side also where the picture is depicting how Paul Brand goes to the houses and make offloading devices according to the foot. So it's very important to understand that the diabetes is a progressive disease, unlike the Hansen's disease, but the deformity is almost similar to Hansen disease. So most often I used to address the deformities in diabetes as modern day Hansen's disease, especially in terms of deformity. So if you look at, I mean, this is very important slide. I always believe that this is a teamwork, but however, what we are trying to understand as a team, which we are going to help you in phase 2 is all about understanding the teamwork. Even if you have one person, you can do wonders because of the advent of telephones and modern gadgets. You can actually link up with multiple team hospitals, and as a teamwork, you can do. It's not that only a hospital of a caliber of Christian Medical College can do. It's actually every hospital, especially in the mission hospital, has a potential to upgrade your skill, upscale your system so that whatever resources is enough to actually prevent as well as treat diabetes foot ulcer. So I thought we will go as a case-based approach where this is a very common problem. So this is a gentleman who has diabetes for 20 years, has come for peripheral neuropathy. We had a detailed discussion of peripheral neuropathy last week, and understandably, he has a moderate NPDR with clinically significant macular edema, chronic kidney disease of stage 4, no macrovascular complication. He does his daily walking holistically and also has no ulcer in the past. So the clinical examination was absolutely normal. So this is the photograph of the gentleman who actually walked into our OPD a couple of years back, and you can see that we think that this gentleman has no ulcer. So I'll treat the diabetes, and probably maybe he will come back to me maybe 3 months or 6 months because its HbA1c is 6% maybe. So, but if you look at carefully, maybe towards the end of the presentation, we should be called this foot as a pre-ulcer state. That's what we want to understand and make yourself think much more and upscale your thinking process, where this foot is a time bomb where patient can get a foot ulcer maybe tomorrow or maybe 3 months or 6 months or down the lane, and maybe an unfortunate amputation as well. So how to evaluate or maybe diagnose a pre-ulcer state is our main aim to discuss in here. So if someone asks that why do we really need to treat a foot ulcer? Okay, probably the patient has no pain, anesthetic foot, the ulcer heals on its own, patient never complains. It's not about that actually. It's about the consequences on renal functions. This study was done in Indian, especially in Madras, in Chennai, where you can see that this study has shown very clearly that if the patient has a foot ulcer, there is definitively a high incidence of decline in renal function was much faster than chronic kidney disease without foot ulcer. So that means suppose somebody has a creatinine of 1.5 and have a foot ulcer and get an infection, their renal function, the functions worsen much faster than those without a foot ulcer. So it is important that it's not about the ulcer which delays, it's about the activation of the other systems where the renal function worsens faster and probably get a chronic kidney disease much earlier than if they don't have a foot ulcer. So we all know that there is a multiple force. I'm not going to the greater detail of it, because if you really want to test on your feet, you just rub your hand for next 10 minutes and see where are the places you have warmth. That's nothing but a pressure in the foot. Similarly, we have also in the foot, there are multiple pressure points where normally pressure point to step, where we are standing, and it is actually helpful in such a way that our system maintains the cooling and temperature balance, so that there is no abnormal temperature elevation in one area. But how unfortunately patient with diabetes has an autonomic dysfunction much earlier, so they have an abnormal increase in skin temperature, which leads on to a callus, probably fissure, and then an ulcer and amputation. So in modern medical, it's all about evidence based. So when we talk about any treatment, any therapeutic aspect, whether it happens in any level of healthcare system, it's all about evidence based approach, because it definitely has a legal implications as well. So when we look at the evidence-based approach, it is the whatever we are going to discuss is actually given exactly in an international working group for diabetic food recommendation. So when we are talking about pre-ulcerative state, it's all about examination and picking up the deformity or maybe an abnormal area much earlier than the patient comes and explain about their problem. So it's in simple medical examination, inspection, palpation and percussion. Probably what the inspection is what you're looking at. Palpation is what about the palpation of the peripheral arteries, which Dr. Prabhu will be coming and explaining to us in much detail. And percussion is all about using a gadgets. So that's a simple way of understanding, which we all know about a medical students long time when we were reading for medicine. But this does not ends there. It's all about is footwear inspection. It's very, very important, because footwear itself can be a pre-ulcerative state where there could be a broken buckle, or maybe there may be and strap may be worn out, or the outer sole may have a small thorn pricking inside, could be anything. So inspection of the footwear by the physician, and also need to educate the patient on footwear inspection almost daily, which will definitely reduce the morbidity in terms of future foot ulcer. So what I will be talking is about pre-ulcerative state and its implication. So suppose somebody is coming to you with diabetes and you don't look at the interweb space area, then you are actually probably missing out a candidal infection, which is intertigo. Probably that may be the root for a small infection, and then they become foot ulcer and then an amputation. So if you look at the primary prevention, there is actually a physician who can definitely make a major role in understanding the primary reason for the future foot ulcer. So as well as suppose the patient is having a callosity, which is not going to cause any problem in a patient with diabetes, because the patient is absolutely will have no sensation. That's why if you are able to recollect that when we were talking about peripheral neuropathy, we mentioned very clearly that please don't examine over the callus area, because the callus area will show a falsely positive neuropathy because they don't have any sensation. So patient never complains, and they probably in turn develop a foot ulcer and amputation. So it's about picking up the primary reason for an initial smaller change in the foot, which is very, very important, and that's how we will definitely be able to prevent amputation in the future. That is very important. And if you look at this causes or reason for this, the patient is not going to come and tell us that I have some whitish patch in my interdigital area, or patient say that I have some thickened skin, patient is not going to complain because they don't have pain. And unfortunately, the anesthetic foot is the problem for all this. But the science has not improved in such a way that if there is a loss of sensation, or let's say protective sensation, it cannot be remained back to normal. So if you look at the pre-ulcerative state, you can see that all whatever shown in this current slide, we all know in, or we would have experienced any of this, maybe dry skin, fissures, very common, callosity, corns, intertigo, and deformed toes, which could be mallet toe, hammer toe, claw toe, hallus valgus, a bunion associated with flat foot, fungal nails, ingrowing nails. So we all know this term already. So if you really put in a little better order, let's say skin, bones, and nails. So if you, when your patient with diabetes comes to the clinic, it is important to look at their skin, bones, and nails in depth so that we can pick up probable a pre-ulcerative state much earlier. So the question was, can we use coconut oil for a dry skin? The dry skin is a very common entity in patients with diabetes because of autonomic dysfunction. And some of the studies have shown up to 50% of patients with early diabetes can have dry skin. And if you ask me, how do you treat it? Just a simple hydration and whatever available cream is enough. But remember that it's not advisable to use oil which is actually has a pleasant odor. So it is better to avoid coconut oil because it attracts rats and insects. And you may be asking why. There are patients as well as enough studies has proven that for some unknown reasons, the diabetic foot ulcer, probably because of the odor from the foot ulcer, they attract rats per se. And if you are using coconut oil, it attracts more number of rats, and we all know that we use rat trap with coconuts. So it's not an advisable to use coconut oil, and it's much common. But whatever other oil which is probably a pungent odor may be a better choice. But if you have a moisturizing cream available or any hydration, maybe liquid paraffin itself is enough. So probably you can see another picture where this is a gentleman who came recently with a bleb because of the abnormal footwear, which was worn out, and he had a small strap which was popping out from his footwear, which was actually having abnormal friction, and he had a bleb. But if you closely look at his opposite foot, you can see in the background there, this gentleman has the other toe showing the bleb. And you can see the right foot has a lot of dry skin. So if the same person, if you closely in the second toe, he had a small rat bite. Basically, this is because he was using coconut oil, and you can see he has obvious dry skin. So this kind of smaller, very important information gives that this is actually a pre-ulcerative state. Many times we thought, okay, this is just a dry skin, and what I'm going to give an additional treatment. But if just giving an moisturizing cream of any of your choice actually can probably prevent any of the problems. So this is a classical example that dry skin, coconut oil, rat bite, and you can see the dry skin is very evident in this. This gentleman needs moisturizing cream, and definitely if you're giving moisturizing cream as well, even if he has an local itching, which is very common in patients with hyperglycemia, they tend to have nail scratch because of nail persistent scratching, and then can have ulcer and also at cellulitis. So it has a major consequences. So a physician definitely of anywhere posted all across the globe, it doesn't need a major gadgets or anything, just a simple primary prevention and education among the physician as well as the patient is enough to prevent a future foot ulcer. Okay, fissures, I'm sure most of us who are sitting here would have had fissures either in your feet or maybe in your, of them. And it's important that the fissure introduces a bacteria within the subacute tissue and can have an local cellulitis and then osteomyelitis. So if you look at simply a cream of choice with salicylic acid, see, somebody has asked what are the other safe natural agents. Whatever your choice, which has nothing, which is not having a pleasant odor is enough, and we can use simplest liquid paraffin, very safe and very cost effective in most of the centers. So we use liquid paraffin in our center for all patients with diabetes, especially if they have a dry skin. So liquid paraffin is absolutely safe. And fissures, so it has to be applied in the night because it has to be sustained in the superficial skin, and preferably a sock is good because that will keep the salicylic acid for longer duration so that the fissures can have a better treatment. So this is a second patient who was a gentleman who has a history of barefoot walking, has a peripheral neuropathy, moderate non-proliferative diabetic retinopathy. Very important to understand that all patients with diabetes should have a retinal evaluation like foot disease. Retinal disease will not have symptom unless there is a retinal detachment or a small hard exudate sitting over the macula. None of them will have symptoms. So retinal examination is absolutely necessary for all patients with diabetes for the first visit, and subsequently depend upon, it does not need any ophthalmologist. If you know how to use an ophthalmoscope, you can absolutely look at it with a tropicamide strop, and you can easily look at the fundus, and foot disease is almost equal like retinopathy. So, and this gentleman has an ulcer in the past, had an amputation, clawed toes in the opposite foot also. So this gentleman has come to the foot clinic recently. Sorry, not recently. Around two years back. You can see that the left foot has a callosity in the fourth toe, and he recently had a bad foot walking, and you can see there is a callus with a subcutaneous hematoma as well. So when you see a hematoma, we all know that blood agar is a culture medium for any of our bacterial infections. So this itself is a bacterial agar similar, where this can be a route for medium for infection. So very important, you can see there is a smaller ulcer beneath when after pairing, you can see around 0.5 centimeter foot ulcer. So this is clearly evident that callus has to be removed, and callosity is definitely a pre-ulcerative state. When you are coming for the phase 2, you will be educated as well as have an hands-on training to how to pair the callosity, which is very simple bedside procedure. I'm sure everyone will be able to do. And in our setup, predominantly our nurse educators are being trained to do the pairing, or let's say in removing of the callosity. So sometimes callosity can be bilateral, or maybe in the stump region, or sometimes maybe multiple callosity, where you can see this lady has come to foot clinic just because she was following with us, not because of she has any callus. She came and mentioned that she want to control her blood glucose level. When we examine, we can see there is a foreign body in the midfoot. That itself suggests that she was probably going for a barefoot walking inside or outside the home, and you can see there are multiple callosity all across. And if you closely look at, she has so probably wearing a toe ring in the third toe, and we will be coming to that in next couple of slides as well. So this all the areas where you can see commonly callosity, and what you can see in the right side of your screen is the occupation related callosity, where if the patient is a Muslim patient, where if your patient sits cross-legged in the floor continuously, or maybe an accountant who sits in the floor, you can see that there may be an abnormal pressure areas, especially in the lateral part of the foot, which itself is a pre-ulcerative state, and need to educate about sit in a smaller stool or using a soft floor mat to sit over it, so that the patient can have an offloading of that particular area, especially when they are sitting cross-legged. So it is important to understand that every aspect of the foot has to be examined in greater detail. But just in inspection, we are not using any major gadgets here. I mean, if you look at all my talk, which over the last 12, 13, 14 minutes, you can see that there is not need a major gadgets. It just need a simple physical examination, which you and me all know about when we were. So this is Okay, offloading is nothing but removing your foot from off the ground. I'm just slowly introducing the term offloading. Is that offload means we are not touching that in the ground, where the foot is off the ground with some maneuvers. That's why it's called offloading. But in when we are using offloading, we can also talk about offload from the ground, where it does not touches the ground. So that is called offloading from the ground. So that the particular part of the foot is not touching the ground is called offloading. So, but when we are talking about offloading of the foot ulcer, that we will be talking in a greater detail on the fourth week of this program, where we will be extensively talking about how to offload a foot from the ground, especially with the existing resources. That will be in a greater detail with a few live patients will happen on the last week of the session. So when we use, so a simple examination of the interdigit, you can see that, so maybe because someone mentioned offloading, I just say that if the patient has cross legs in their, when they are sitting, putting a stool will offload that particular lateral part where they sit, and the foot will be straight, so that the lateral part of the foot is not touching the ground. So that is why we call it offloading assay. But if you look at the books, they say offload is only about the plantar aspect, but not that way. If the other part of the foot is touching the ground, especially in patients who are sitting cross-legged, if they sit straight and in a smaller table, again that is called offloading as well, the description. So if you are looking at the interdigital space, many a times you can see that the patient can have an intertigo, and if you closely look at the next picture of your right, the patient has a subtle degree of cellulitis around the skin and some necrotic tissue around that. So this is a early sign of cellulitis in the particular area. But if you don't look at carefully, probably this will ascend into an full-blown cellulitis, probably necrotizing fasciitis, and probably an amputation as well. So simple treatment with an antifungal of your choice, which is available, will be an adequate enough. So let's have a discussion here. So what do you see after talking about all this? What do you see in this picture? Photograph, what do you see? You can type it in the chat box. What exactly you're looking at? This is an amputated right foot, patient with diabetes, as with all microvascular complication. What do you see here? Dry skin, right? So it obviously need definitely liquid paraffin, which is easily available for this, and education about not using oils which attracts rats or insects. Anything else? What do you see in this callosity in the prop? Yes, there is abnormal callosity in the because of the straps, which is probably a worn out footwear, which is actually has an abnormal pressure in the dorsal aspect. What do you look in the nails? Yes, deformities. Patient has a claw or mallet, whichever. Can see the nails. Nails are dystrophied. Yes, claw toe. Flat foot probably may not be evident here because I have not shown the lateral aspect of the foot. Maybe there. Yes, very good that people are looking at. See, it's all about sensitizing to understand and look at the feet that this all are actually an pre-ulcerative state. If we are not taking care of this, probably this gentleman has this problem much earlier than the amputation probably not been taken care of. So that's what we need to understand. So this is an abnormal callosity in the amputated grade 2 per se is a risk for future foot ulcer. Yes, amputated grade 2. If you look at the studies that if someone has an amputation of a one toe or maybe of a major amputation, at 5 years, there is a 50% chance to get a foot ulcer in the opposite foot or an ipsilateral foot, as well as there is a further 50% increase in the amputation in the ipsilateral as well as the contralateral foot. So you need to remember that that's I'm not sure what exact limbs swallowing. Okay, fine. So further to the discussion, the other very important area is cons. So if you look at cons, the abnormal pressure, then continuous abnormal pressure develops a cons because of so many pathophysiology behind it. But however, remember that many a times if the cons are not taken care of properly, they end up having an infection. Corn caps are not a good option because many times it precipitate an infection, and catalytic agents like salicylic acid of your choice would be an ideal to use with pairing. And if it is deeper, definitely need a surgical assistance and further offloading with the footwear that we will be discussing in the fourth week of the session, how to offload and foot ulcer. So which is altogether is a different discussion. Offloading is nothing but where you offload your pressure from the ground, where when you're touching, when the patient is walking, that particular area has lesser pressure distribution than the other area. That's called it's offloading. So can someone briefly mention what exactly you see in your cons? You can use either 6% or 12%, but remember that most of the time cons, what we do in our setup is use 6% or 12%, soften it a little bit and then pair it. That means remove it, try and remove it. And most of the times we end up needing a surgical assistance. But remember, smaller cons, you can use 6 or 12% salicylic acid and soften it with those and then remove it. So probably maybe we'll little concentrate on the nails here. Brittle nails are deformed. Fungal infection, absolutely right. So this is a classical nails you see in patients with diabetes. You can see, in fact, all the nails has fungal infection in this lady, and you can see brittle nails, and she has a bit of an ingrowing nail in the first two as well. So fungal nails are very, very important. It's absolutely important to educate your patient with diabetes about hemato, malato, all are very important. Good that you are looking at every aspect in this patient. So, but here I'm going to concentrate on the nails, because most of us have the habit of cutting the nails with the edges and try to remove out from the edges with our hooks, which are available in the nail cutters. So remember that educating the patient not to cut the nails is very, very important. If they want to cut it, also not to cut in deep, cut it straight. And most of the patient with diabetes and have a fungal nail, it's good to talk to your dermatologist ideally. But if you have any fungal cream of your choice which is available, probably it needs a longer duration. But one thing very, very important I would like to emphasize is that educate your patient not to cut the nails. That itself will prevent foot ulcer, because most of the patients come to us here is had a paranoia. If you ask a history in depth, they would have had a nail removal on their own, or nail paring on their own. The next is very important is ingrowing nails. Most of us would have experience in our lifetime, but this particular problem in your relatives on your own itself. But remember that there was one interesting study which has mentioned that patient with peripheral artery disease was found to have more ingrowing nails. So that's has a lot of bias. But remember that when you're looking at patient with diabetes, it is important to look at the arteries before removing the callosity or removing the corns or anything, because it's absolutely important. If you're not palpating the arteries and look for the adequate blood supply, that means we are going to do more harm than good. So second is very important is educate your patient not to remove the ingrowing nails. Surgical intervention is most often is required, and it's a simple surgical procedure which can help in this ingrowing of the nails. And education is a foremost. Simple education will prevent future foot ulcer. I'm sure this is evident from the slide itself that patient has abnormal bone injury in all the pressure areas. This is very common in patient with foot diabetes and anesthetic foot, which is peripheral neuropathy. And where we all enter our religious places barefoot, and if you're not educating the patient, probably patient walks barefoot in the temples or mosques for longer duration and end up having an foot ulcer of this. And this is recently we taken it on our outpatient department, where you can see that this patient went for a pilgrimage, barefoot walking for an hour, and after 3 days she noticed blebs all across, all in the bilateral feet, and you can see that there were absolutely burned skin all over. It's a very classical of barefoot walking in religious places. So how do we tackle this? So would someone like to briefly talk about let's say, concentrate on the left foot. No need to talk about no need for the right foot, where we have offered an interesting device which is called toe separator, which is available in the market. We'll talk about this a little later. And what exactly you see in patient with in the left foot. Yeah, previous slide has a multiple this is that is predominantly because of the barefoot walking and neuropathic ulcer. Predominantly, that lady had a good adequate blood supply, where she walked barefoot in the temple for, pilgrimage for an hour, and she came back with multiple site ulcer because of the barefoot walking, because she was walking in the the mid noon when the temperature in was high in a pilgrimage area where she went for her yearly pilgrimage. So it was actually predominantly a neuropathic ulcer, and though it looked like a neuroischemic in the slide, but the peripheral arteries were absolutely normal. Yeah, overriding of toes, very absolutely right. This is what, if you don't take care of the discoloration of thin in the third toe, because she had a small osteomyelitis, because closely look, you can see that there is a local gigantism. So overriding of toes is very, very many times. If you closely look, the first toe, this is the same patient I showed before, the right foot, and this is the left foot. You can see that the toe nails are brittle and has a fungal infection. The second toe is overriding the first toe, and definitely there is an abnormal pressure. So when we talk about abnormal pressure, we talk about abnormal pressure in normal foot, but here the abnormal pressure can be because of the neighboring toes, also the next toe also, which is the greater toe, and this lady also had osteomyelitis of the third toe, which is, in fact, interestingly, there was no sinus tract. So when a patient with diabetes comes to us, we generally, if there is deformity, we generally take a foot x-ray to make sure that there is no other areas of involvement in terms of osteomyelitis, because of late we are seeing more and more patients with osteomyelitis with concealed nature, where there were no sinus tracts. So it's important to understand that chronic osteomyelitis in patients with diabetes is much different from the chronic osteomyelitis we can see in for other diseases. So that's why I want to understand that chronic osteomyelitis can present without any problem. So coming back to the religious place and the usage, so we generally ask them to use a sock with an insole which is inside. That means that there is a silicone insole if the sock, which is shown in the right side of your screen, and the left side is where the insole is fixed on the sock outside. But the only difference is that the sock, which has outer sole which cannot be washed frequently, and if you have an insole within the sock, you can actually wash the sock very frequently, and it's can be reused because you are removing the inner sole and washing the sock. So it is very important to understand that education, and now right now the sock with an insole is very easily available in the online marketing. You can use it very easily, and it's not very expensive. It's actually cost is around 200 300 rupees much, and if you look at an amputation and consequences, it is much cheaper than this. And educating the patient nowadays, what we are asking is to advise, if suppose the patient is not keen on wearing a footwear, we advise to use a sock with an outer sole, or maybe using an insole within the sock to use inside the house as well. Those are patients who are not keen on using a footwear, and it's very cost effective, and it actually helps at least to prevent certain degree of foot ulcer in patient with diabetes. So next is ring story. I always like a ring story here, because if you look at when we talk about abnormal pressure, the abnormal pressure can be because of footwear, or could be because of the deformity, or could be a foreign body which is there in the patient is wearing or using. So here it's a toe story where you can see that the patient was using a toe ring, and subsequently developed, and you can see in the center where you can see that the patient has callosity here. And interestingly, the patient also developed osteomyelitis because of the persistent friction of the ring to the next toe. So, and then this is another patient where you can see that it developed a foot ulcer as well. So it's very important to explain to the patient where if they have diabetes, there it's not about the footwear or not about the foot per se a deformity. It can be something which can be a foreign body also, or an external agent also can have an impact in the foot ulcer. But it's not easy to explain to the patient how, and it's important to understand from the medical healthcare professional. I need to think about possible reason for uh, an infection in the future. You can see that gentleman which I showed in the initial picture as hallus valgus, where you can see that if you closely look at that, there is an overriding of the first toe over the second toe, and there is abnormal friction. And in the second picture, you can see there is a small callosity in the second toe where there is because of the straps. And then third picture, you can see that this is a bunion, where we can actually, because of diabetes and also an ulcer. Yeah, that's a good question. Poor glycemic monitoring could be anything. This is because of diabetes, could be because of the barefoot walking, long-standing uncontrolled diabetes. It's per se is very important. Yes, primary prevention includes and glycemic control at any cost. HbA1c of less than 7% would be ideal without any hypoglycemia. Yes, but this all patients who come after 5, 10, 12 years with uncontrolled diabetes and never taken care of them properly. But glycemic control is the primary prevention, which I am not going into the greater detail because that is the important feature for any of the primary prevention. But what we are discussing is about the level where it's very, very important that we also taken care of this, because this, if you are not, in spite of having a good glycemic control, if you are not taken care of this, this will develop into a foot ulcer. Okay, this I have. So a little bit about why claw toe or mallet toe or claw toe, I mean hammer toe is important, where it's not about the abnormal friction in the plantar aspect, it's about the abnormal friction in the dorsal aspect also. So we can see the few slides back where there is a small callus which can develop into the corn, or maybe callus in the plantar aspect. So when we talk about an abnormal pressure, textbooks talks about more of an plantar pressure, abnormal pressure points. It's about the dorsal aspect as well, which need to be taken care of. When we are looking at the foot shoe, suppose the patient is using a shoe, that also can sometimes cause abnormal pressure from the sides, and they can have an abnormal pressure causing the crowding of the toes and causing abnormal deformities as well. So this is all may develop into a foot ulcer as well. So we will be talking about more about strap modification and how to tackle this when you are coming for the phase 2, and also will bit of a discussion will happen in the last week, where sometimes if the patient has a claw toe where there is a friction in the dorsal aspect, just pull it back the strap. But this needs definitely a little bit of an expertise. But we will, the whole idea of the program is to educate the physicians, then educate the healthcare professionals, make sure that the healthcare professional understands and start treating. And then next level is about helping a few of the orthotics people who are interested in orthotic to use appropriate footwear and use the existing resources to make footwears at their hospitals where they are working. So this, the whole exercise is about taking it to a level there where whatever we are prescribing should be prescribed in the primary healthcare level itself, because diabetes is a very common disease and it should be treated by everyone who's there all across. Sometimes you may see few interesting things. This is a lady who came to us, and when we examined, there was a callosity in the greater toe because of there were no abnormal pressure. We were not able to figure out why. So we thought when we pair it by removing, after examining the pulses, which was adequate, so removed it, and we found that there was actually a small glass piece within. We have seen glass pieces, to earrings, smaller stones, multiple foreign bodies inside the callus, because that sometimes gets inside and causes small abnormal pressure, which you may think that because of something else, but this is a story where you can, if you are closely look, you can see a small a couple of millimeter of a small glass piece within. Okay, this let's go to a little more different angle of understanding about diabetic foot pre-ulcerative state. So this is a gentleman who has diabetes, chronic diabetes, poor glycemic control, came with an ulcer in the right foot, and I'll just show the picture. So what do you see here? So what are the things maybe you can use a chat box and put it in chat. What do you exactly see on this patient? Yeah, neuropathy, definitely. That's why patient has clawing and hauling in the right toe and probably an amputation. Exactly. Ulcer, very evident. There is a tropic ulcer. That's right. What else you do? What else you see? Hallus valgus in which side? Multiple toes burn. Which side is? Can you please elaborate, SDMS team? Where in the right foot or in the left foot? Fishes on left foot, absolutely. Because when maybe around few years back, when I start getting interest in the diabetic foot, I always look at the left foot because the patient, right foot because patient comes with the foot ulcer. So we focus on the right foot, say that let's say we treat with this probably debridement, amputation, all this. But if you look at the opposite foot, it's already started developing a pre-ulcerative state in the form of callosity, fissure. Somebody has absolutely said right. So the left toe has already started, the pulses were adequate. It is actually a callosity and the patient was barefoot walking. So that's why there is a discoloration. You can see there is a callosity in the greater toe because of the barefoot walking, that there is dirt in the greater toes. So there also, if you see closely look, there was a small fissure, maybe not be evident in your screen. It's evident in our bigger screen here. So this are a pre-ulcerated. So we many times we are carried away with the abnormal ulcers or many things and may not be looking at the opposite foot because opposite foot is high risk in terms of pre-ulcerative state. And as I already mentioned, osteomyelitis as another area where they can come with the pre-ulcerative state, no symptoms. This is a lady where you can see that there is osteomyelitis with the terminal phalanx being absolutely eaten away. There is no discharge, nothing. Patient never had antibiotics. Patient mentioned that she was normal anesthetic food, so they never comes with the history or suggestive of sinus or a oozing tract. So this we'll be discussing upon osteomyelitis in the next time. So I'm not going to the detail of how to treat and how we need to evaluate. So osteomyelitis per se can be a pre-ulcerative state. They may not come to you with thing. So can someone say that what exactly seen? This lady came to us few weeks back to our peripheral center, which is Chittu Clinic, where we had a foot clinic with our PMR physician, physiotherapist, and endocrinology and surgery, where we have a multidisciplinary clinic as well. Patient came for a callosity in the fourth metatarsal region. What do you see on this patient? So whenever it's very important to do a simple X-ray in most of a patient because X-ray is not an expensive test and the availability is pretty much better than in the past. So we always do a X-ray and after the examination. Okay, so this lady, if you see closely osteomyelitis, this is a small, if you look at the spaces of the other metatarsal region, you can see there is nothing in that, and you can see this lady was having a smaller degree of osteomyelitis already developed. And remember that this patient came for callosity and has come for, actually speaking, the patient came for diabetes and clinical evaluation of diabetes and glycemic control. On looking at the patient's foot, patient was found to have a diligent physician brought to us saying that patient has a callosity. When we did an ultra X-ray, we found a small probably signs of osteomyelitis, and then we did an ultrasound. We found there was a focused septic arthritis, and the PMR physician helped us in removing a small pus point, and then we treated with antibiotic and further offloading, which we'll be discussing the further week. And the patient was absolutely asymptomatic. We were able to prevent an amputation. So this is a story of how a callosity, which could be, you can pick it up early and prevent a future amputation. So when we talk about how what we are talking to discuss past few minutes is all about how to pick up certain problems in pre-ulcerative state. And next few minutes, I'll just run through what are the materials available to use it. But remember that we are just highlighting and we are not saying that this should be used in your setup. But remember that some of the things are advisable to use and some of things are not advisable. But remember the first three, microcellular rubber or an ethynyl vinyl acetate rubber or microcellular polymer, which is famously called an MCP, or the very easily available insole. Remember that when we talk about insole, why insole is very important is that insole should be neither hard nor soft. If you recollect the last peripheral neuropathy discussion, we use something called durometer, which is actually helps in understanding the softness, or maybe let's say in other words hardness of the rubber, which can be used in patient with diabetes. So that's why the top three are very important. The bottom five are available but not freely available, but have this own cost. But if you ask who should be prescribed footwear, in fact every patient with diabetes, because in Indian context our flows are hard, and also there is high risk for foreign bodies. And also remember our neuropathy, if you look at the neuropathy, we advocate a much lower degree of monofilament than what is given in the textbook. Textbook says 10 gram monofilament, we use 2 gram to pick up a neuropathy much earlier, because barefoot walking and the hard flows within the house and cultural habits of removing our footwears when we enter anybody's home, and even in our own homes we don't use footwears within the home. So considering that, it's very, very important to prescribe footwear for everybody with diabetes. And what we are doing is to prevent pre-ulcer, and if there is an ulcer, prevent a future foot ulcer. So this is all about pre-ulcerative state and probably how to pick it up. And but if you look at the guideline, they'll talk a little more in depth. But remember that we won't be going in depth of this, because some of the things will be done as a phase 2, because this needs more of hands-on experience to understand and use certain offloading devices. And I won't be talking about surgical offloading, which will be dealt in greater deal by a plastic surgeon of experience here. So I'll be talking about toe devices and I'll be highlighting, but I won't be going into the greater detail, because when you're coming for the phase 2, we have a hands-on training to how to use individually here. So I won't be going to the data. But if you look at the guidelines, when to use toe devices, what is called toe devices will be shown in the next slide. When suppose patient has a callosity or recurrent ulcer, you have to do it. But what are these toe devices? The toe devices are nothing but the gadgets which can use to make the toes straight or back to the normal anatomy. That's why it's called toe devices. There are multiple toe devices. I'll show in each differently, but how to use it, you may be wondering, can we use this? But what the guideline talks, we'll come into the next picture. So there is something called toe separator, where they can separate the toes. A bunion cap, where you use the bunion, whereas the toe is has a hallus valgus, so then it has to be straightened a little bit, and also to wear a bunion shield so that the ulcer is not this is all being used in the normal patient. To understand that, when you come here, we'll be helping to understand with the abnormal feet as well, abnormal deformed feet as well. And so this all, someone asked, no, this all are made of silicone. Remember that silicone is used for offloading, and these devices are made of absolutely silicone, with has a good durability as well. So that is why it is not, devices won't cause pressure at all. This is all made with silicone or with material which is used for as an insole. So toe prop, metatarsal part, this all have been used. There are toe caps for multiple toes. Then there are toe separator for 2 toes, 3 toes, 4 toes. It's all are important. So let's say what you think this lady has. Someone can quickly put on the chat box what are the things you see in this patient. The patient has an amputation under your care, the greater toe amputation, and the patient has come to you. What are the things you have? What are the things? Amputation of great toe. That's why the patient has come to you. Hammer toes. Yes, absolutely. The second toe. What about the second toe in this patient in the right side? Dry, callus, ulcer in the left toe. Left toe ulcer, left foot ulcer, left foot. I'm not very sure where is the ulcer, but that's fine. Deformity, yes. Osteomyelitis occur could be if you do an X-ray, maybe. If you nails, yes, nails. Look at there is the third toe. There is probably had a surgery already, and the nails are missing. This second toe also has an osteomyelitis, probably because there is local gigantism. There is a claw toe. There is dry skin, and some eczema the skin here, dryness. Okay, this I think whatever we have spoken is adequate here because you are able to pick it up. Most of the things which you can see in the screen here in this patient, where you can see dry skin, deformed toes. There are evident to suggest small muscle wasting. That means motor neuropathy. And the nails are brittle in the predominantly in the right, and probably in the left second toe has a little brittle nails, and probably signs of osteomyelitis as well in the right second toe. Okay, let's go back to how do we treat. So this will be dealt in greater detail. I'm just giving an eagle's eye view of what exactly we do. So if you look at the deformity in all these patients which we have spoken till now, if you look at the deformity, is all in the forefoot. It's nothing in the hind foot or midfoot. If it is in the midfoot or hind foot, it is predominantly Charcot's arthropathy. So I'm not saying that Charcot won't happen in the forefoot. It do happen, but if there is a descent of the midfoot or maybe in the posterior displacement of the calcaneum, it's all about having a Charcot. So it is all in the forefoot. So I am introducing a term called anterior rocker. Don't worry about it. So it will be discussed in the same slide, will be discussed again and again in the next week, as well as in the subsequent week. There we will be showing what exactly is anterior rocker. But don't worry about this. It's all about sensitizing about certain terms and understanding within a span of 1 hour. And there is a more discussion when you come here, and the subsequent weeks also has a lot of discussion about what is anterior rocker. So what we do is when the patient has a clawing on the forefoot, we use something called anterior rocker, which will be discussed in the osteomyelitis class. So that is what we use it. And if there is a recurrent ulcer from there, then you have to use a toe device. That is what the guidelines talks about. But interestingly, their way of putting in the guideline is slightly different than what we read. But this is what exactly is being modified from International Working Group for Diabetic Foot 2023. It came last year, May, and the CMC protocol is actually gel with what we are using way before. So once the patient uses an anterior rocker of 8 to 15, don't worry why the 8 to 15 degree. We have a detailed discussion next week. And then we use the toe devices. But remember that this toe device, if somebody asked, very beautiful question, can it be a pressure? No, this is actually made of silicone. It's not very expensive when the patient has a hammer toe, in spite of using an proper anterior rocker, let's say 8 degree. If they have a persistent callosity, which you needs a debridement, then we use toe cap, bunion cap, or toe separator. But remember that it has to be used with a sock. Remember, finally, it's very important that footwear with modification also is required, where we cannot take away. But this is just a highlight to understand. But remember that picking up the preulcerative state is very, very important rather than using all these gadgets. Because when you start understanding about the last discussion about offloading, you will automatically start prescribing a footwear for this patient. So the whole idea for this class is to understand about the common preulcerative state which need to pick up in patient with diabetes, which can be treated easily. So it's important that simple foot and footwear examination prevents a foot ulcer. Individualize a footwear, it's not same for all patient. Simple treatment with whatever existing resources is adequate enough to prevent the future foot ulcer, and especially in patient without foot ulcer comes for diabetes evaluation, needs a foot evaluation, and you can pick it up much earlier and prevent a foot amputation. And thanks you for patient listening.